Hi there. Welcome. My name is Kate Breslin, and I'm the president and CEO of the Schuyler Center for Analysis and Advocacy. We're so excited to welcome you all here today, and super excited to welcome our visitor, our guest, Kinda Serafi. My name's Kate, and the Schuyler Center is this year celebrating our 150th year, trying to shape public policy so that it benefits all New Yorkers, not just people who have resources or wealth. And we've always had a particular focus on people living in poverty and children and families. And we are very proud to be the fiscal and administrative and staff home for Medicaid Matters New York. And I'll ask Lara Kassel from Medicaid Matters New York to introduce herself.
Thank you, Kate. Medicaid Matters is the statewide coalition representing the interests of people who are covered by Medicaid in New York. As most of you probably are aware, there are many competing interests when it comes to Medicaid in New York. And we bring the very critical and unique perspective of lived experience, people who are covered by Medicaid, and we bring that interest to the table as it relates to Medicaid policymaking and budget making. And you can find us online and on Twitter.
And Kinda Serafi is an ally and a colleague. She works at Manatt Health, advising on the legal, policy, and operational challenges of Medicaid, the Children's Health Insurance Program, and marketplace coverage. She has significant experience with an array of clients of Manatt, including state government, foundations, providers, nonprofit organizations, and working with state governments. Kinda provides strategic counsel, policy analysis, and implementation support. Serving as an advisor to the Robert Wood Johnson State Health and Value Strategies Program and for the CMS Medicaid and CHIP Learning Collaboratives. She's a subject matter authority on Medicaid eligibility and enrollment. Prior to Manatt, Kinda served as the director of policy of the Children's Defense Fund in New York, where some of us got to know her, where she developed strategies to simplify rules for public health insurance and expand eligibility levels. Does that sound familiar? She also worked in legal advocacy and organizing at Lenox Hill Neighborhood House, as a law guardian at the Legal Aid Society, representing abused and neglected children, and as deputy director of programs and policy for Children's Defense Fund in Washington, D.C. We call her a friend. It's great to have you with us, Kinda.
I sent you a much shorter bio for the record, and you know it. It was one sentence, too long. Thank you so much.
We already had that one.
Such a pleasure. Such a pleasure. Thank you. It's like coming home.
Oh,
Wonderful. We're so thrilled to have you today. 2023 will mark the 20th anniversary of the forming of what is now Medicaid Matters New York, which is pretty exciting.
Amazing.
Yeah, and you have the unique perspective of having been in the advocacy world, and now you have the unique perspective of being in the position that you're in now. And I wonder if you could just take a moment to reflect on what this anniversary means, and what that means as far as the importance of Medicaid consumer advocacy.
Yeah, of course. So just to say, we were just doing the math. I was a Medicaid Matters member, card-carrying member when I was at the Children's Defense Fund, the director of policy in the New York office, starting in 2007. So this is my 15th year anniversary, if you will, of being a loyal ally to Medicaid Matters. And I've been at Manatt for about, I'll be heading into my 13th year. And I've had the privilege of being on the advocacy side of it for 10 years, legal aid and Children's Defense Fund. And then now my work is really advising state Medicaid agencies across the country, as Kate had laid out. And the importance of this inside-outside game can never, ever be underestimated. I mean, I think the work that I did with Medicaid Matters, we did with the Children's Defense Fund, was so important because the state needed us to be doing the work that we were doing. And now that I'm on the state side, I cannot tell you how important it is that the advocates do what they're doing. And we're so many times that we roll out with state Medicaid agencies big transformational things, and we just don't know how to do it, like in full candor, like even the best and the brightest of the best state Medicaid agencies are like, look, the legislature passed this, but we don't know how to operationalize it. So we really need the advocates to tell us what this is going to mean on the ground. And B, there are some things that when I work with states, that they're asked to do that they don't want to do, or that they feel like is not for the best interest of the consumer. And they really need the advocates to have their voice and put things in paper and really push so that they can say, look, we tried, but in truth, the advocates have told us. So it's never in my perspective, sort of one against the other. It's like this super partnership and everyone's playing their role and everyone needs everybody to do all the things. Like that's sort of my perspective. So I feel so happy to be a part of this anniversary just because I've been able to see both sides and just how important all of it is and how important the Medicaid Matters work has been in terms of where you are now in New York. Just extraordinary advancements that you have all pushed forward over the last 20 years. It's really incredible.
Thank you. It's a really nice reminder of why we do what we do and why we need to keep doing it.
Yeah.
So thank you.
And one more thing, because I know we have a million questions, but one thing to say about the lived voices is really the most important thing. And I feel like New York and Medicaid Matters is on the cutting edge of that. It's easy to be a consumer advocacy group that speaks from the, ivory tower, but if you don't have lived voices that are actually talking about the impact, then it's all meaningless. So what you're doing and your goals and your mission to always put the consumer at the center and the person with the lived experiences at the center, to me, feels like the most valuable thing that you could bring to a policy and operational table is that perspective of how this all means. What's it all going to look like for the actual individual who's going to be consuming Medicaid services?
Awesome. Thank you. So we are here today to talk specifically about Medicaid and kids.
Yes.
So let's start with a few basics. Medicaid and the Child Health Plus program cover over 2.5 million children in New York State. Children make up 36% of all Medicaid and Child Health Plus enrollees, which is all totaled is over 7.2 million. So thinking about that, those numbers and how important those programs are, and again, starting from the basics, how do kids become eligible for Medicaid coverage? And tell us the difference between Medicaid and Child Health Plus.
Sure. So let's just say this. I think sometimes people think Medicaid, if you're on the call and you're not a Medicaid nerd like we are, you sort of don't really understand the breadth and the depth of Medicaid. 1 in 4 kids are on Medicaid. That's an extraordinary number. Every 4th child in this country is enrolled in Medicaid. And then that doesn't even include children who are enrolled in CHIP. So it is the delivery system for 1/4 of all the kids in this country. You can't not figure medicating kids is one of the most important things that we could do as a country to invest in our society. So with that sort of as the backdrop, which I find extremely compelling to me because it always sort of keeps me motivated on the work when I'm having a really bad day. I'm like, okay, 25% of the kids in this country need this. Let's get on another Zoom call. So, I totally keep that as my North Star. So in all across the country, and specifically in New York, you have to meet eligibility criteria. New York has done a really good job at making it as simple as possible. So you have to be a resident of New York, but that doesn't mean you have to reside here for 1,000,000 days. You could have come in tomorrow, and if your intent is to reside, that's good enough. You have to meet income rules, which is your income has to be below a certain threshold. But because the way that Medicaid and CHIP has been designed in New York, pretty much every child who's uninsured can enroll either in Medicaid or in CHIP. That's sort of how they've established it. That New York is at the top of the country in terms of its eligibility levels for kids. Do not ignore that fact. We always go to other states and we're like, what about New York's model? And they're like, we're not New York. And we're like, okay, fine, just we have to try. So, you have this incredibly expansive coverage paradigm for Medicaid and CHIP enrollees. Medicaid is for the most low income people, and CHIP are for people who are moderate income. So it can go up to $80,000 a year for a family of 4. And then as your income goes up, so let's say you're in that $60,000 a year, $70,000 a year, you'll pay premiums, but the premiums are pretty modest, and well below, I think, about 2% of an income of a household income. So you have to meet residency, income requirements. You have to meet citizenship and immigration requirements. Again, New York is pretty generous in its immigration requirements. You have to be lawfully permanently residing. And then also New York has some pretty generous undocumented coverage programs, which I'll actually defer to Lara on it. But I know New York is sort of at the cutting edge of making sure that it's not just people who meet immigration requirements, but that people who have undocumented status. So that's the sort of big picture of who can get enrolled in Medicaid or CHIP or child health.
Thank you. Thank you.
As Kinder pointed out, New York is really a leader in providing coverage to young New Yorkers. So yay, I feel like we always need to recognize that. I mean, in so many other states, so many of the kids who are covered here wouldn't be covered. And again, for those of you who aren't, super nerdy on Medicaid, every state has a decent amount of flexibility to set their own rules on eligibility. And then they also states have a certain amount of flexibility on what the benefits are within Medicaid and CHIP, less so though with kids. States are a little more, so once a child is eligible, states are a little more, I guess, confined to certain parts of the what kids are eligible for. So we're really excited to kind of think about the so many ways that Medicaid is important to kids and families. And, we approach it from a health frame as well as an education frame, from early childhood up through schooling, and a family economic security frame. So can you talk, Kinda, about sort of why public coverage is so important to kids and to families?
Sure. And I said I couldn't monitor the chat, but I see Elliot has a good point. So when I was at the Children's Defense Fund, all I focused on was coverage and eligibility. That was sort of like, how do you simplify the enrollment process? How do you make it easier for people to get enrolled? How do you make it easier to stay enrolled? Worked on how to make the application easier, all the things to get the card in your pocket. And then when I started working with states, I was like, oh, like this is step one, and then there are literally 150 more steps on the journey for access to services. And that's really, I think, where the work has to happen now, especially since we're at an uninsurance rate nationally at 5% and under. And I think New York is really, it's got like the lowest uninsured rate for kids that it's ever seen. So now it's really about how do we focus on the delivery of services so that people actually can get access to their care. And it's not just the primary care, because that's pretty good. New York is pretty excellent in terms of its access to pediatric primary care. It's about specialty care. It's about access to behavioral health services. It's about access to making sure that populations, children and families who are particularly have challenges with navigating a complex healthcare system, understand where to go and how to go and have their different specialists talk to each other. There's a universe of work that has to happen, that's happening in New York for sure, amongst all of you all, that is the real work. It's like, okay, we've solved this first problem of let's get you in, and now how do we make sure that the treatment that you get is quality, that the providers are getting reimbursed so that they at a certain rate that makes it so they want to continue to participate in Medicaid, and so that kids can go see the specialist that they want to see. And you know, the healthy kids in New York are seeing their doctors, and they are getting treated. Their delivery system is managed care. They're going to see their primary care doctors. They're hopefully going to get their annual visits and their well child visits and their immunizations. And I think that's all humming along. It's really about how do you make sure that the delivery system for poor Medicaid children who are disabled, who have high special needs, and who, you know, for example, Kate, you were saying that there's a mandatory, you weren't saying this explicitly, but that there's a mandatory set of benefits that everybody has to get when you're in Medicaid for kids, and it's called EPSDT. And basically, the state has to guarantee that every child get all medically necessary services that they are entitled to. That has to be covered under Medicaid. And it's complicated because there could be kids who are eligible for medically necessary service, but can't get access to a particular specialist that they need in a reasonable amount of time. And that's, you know, an issue in New York City, and it's an issue all across the state. So in terms of what matters, in terms of why is Medicaid so important, it's the security that families have to make sure their kids can get the treatment that they need. And it's really, I think, where the work has to happen in your next 20 years as you're moving ahead, is really making sure the quality of the care is as good as it should be for everybody in New York.
And I think I would say, I would add on to that that we're considering sort of, I think there's this perception that all kids, you know, all kids are healthy except for a handful who are exceptionally not healthy. And I think what that fails to recognize is that there are a lot of kids who might be there might not be a diagnosis yet. And this is particularly true, on the behavioral health side or mental health side, where there might not be a diagnosis, but there are all kinds of indicators that there is a likelihood of problems. And we shouldn't be waiting until there's a diagnosis.
Agree.
And I think there's a big sort of a vat of opportunity there that a lot of us who are, you know, here on this call are thinking about. And how do we, and if you can kind of point to other places where you think they've done well with that, where, you know, whether it's working more with a family and using some sorts of screening tools that get at some social determinants of health or other kinds of things that identify risk, to intervene before a hospitalization or some other, you know, acute incident.
So it's such a good point. And what I've seen across the country, and it will be a lift in New York because it's a lift all over the place, is the quality of the care management that's happening by the managed care plan. And right now we live in a world where the managed care plans are delivering the services, right? Like most people don't know New York State of Health or Medicaid, right? They know their Blue Cross Blue Shield or their Fidelis or their Health First. That's who they think, that's who's covering them. And quite frankly, that is who's covering them. That's the delivery system. They have their managed care card. And what we put all this money, and plans are getting paid so much per member per month to manage the care of individuals and kids particularly, right? And what happens is they're getting a lot of money per kid per member per month. And for like some kids, kid goes to the doctor once a year, and then they just got a full year, a lot of capitated payments and not doing anything. So what we're seeing states do across the country is like taking a hard look at the contracts and seeing what are the prescriptive levels that we can have our managed care plans do that's beyond just like, hi, I'm going to call you on my telephone, but can we have in-person care management? What percentage of care management has to be done in person? And how do we do stratification? That's not just the sickest of the sickest, Kate, but the people that are sort of pre-diagnosis, but could be at risk because they did a needs assessment and they were able to assess that by doing that. And that helped them figure out, oh, before you have decompensate and have to go to the hospital, we actually think you'd better off if we could get you into behavioral health treatment, you know, all the things that the money for a care manager is supposed to do, but it's just not being actualized. And that's where we've seen this sort of like most progressive states are really squeezing their managed care plans and saying care management's the heart of what you get paid to do. What's your care management, and how can I as a state make sure that you're being held much more accountable to managing the care for the range of individuals that are not just, as you're saying, the sickest of the sick, but the people who are pre-diagnosis. I don't know if it's something you've seen in your journey in New York, if there's been some efforts to tighten those screws.
Well, I think there have been efforts, and maybe not enough, and maybe not intensive enough looking, as you just suggested, sort of really diving into the contracts.
Yeah.
But I think to one of the people, submitted a question around, okay, New York covers a lot of kids. Why is New York spend so little comparatively on our child population? And so I wonder if it goes back to what you just said, that there are ways that the state pays managed care organizations some amount, and there are still a lot of barriers for the kids to get the care that they need.
Yeah, I mean, I want to say, when I was at the Children's Defense Fund, I had a perspective about managed care plans, and it might not have been the light most favorable to the plans, just because I was more naive about how it all worked. Now I feel like managed care plans are the delivery system. They need to be held close, held accountable, and also doing the work that they need to do. It's not the state that is delivering the care, it's the managed care plans that are delivering the care by contracting through their providers. So as a consultant, one of the things that we are always doing for states is we are taking the contracts, we are looking at care management, and we are like really line by line, and you'd be surprised, sometimes the care management requirements are pretty thin, and they defer to the plan to have its own proprietary perspective on how delivery should be happening, and who gets the risk stratification, and who gets a care needs assessment, and what does the care plan look like, and they leave it all to the plans. But this is where states now in the last 5 years have been moving to a much more prescriptive place. And I think it would behoove you all to kind of take a look. It could be you have really strong contract requirements, in which case then we need to be looking at enforcement mechanisms, right? So but if it's not, then that might be an opportunity as well.
Thank you.
Yeah, all of that is so very interesting and very relevant to so many of the conversations that we're having right now about how the state reaches greater health equity. The state has these stated goals of we need a more equitable state. Well, how do we make that happen? These are the types of things that I think we all need to be looking at. What are the nitty-gritty details? What are the requirements? How is care delivered? Because that will be how we actually reach greater health equity, when we drill down on some of those real weedy issues.
Yeah, right, exactly. It's like, what are your policy levers, and how are things being communicated in contract, in clinical policy guidance, in your sub-regulatory guidance, and what are the enforcement mechanisms? That's sort of where the rubber always hits the road.
Yeah.
What financial sanctions are in place? What do plans have to pay if they're not complying? What do they have to meet in terms of expectations? That stuff is the most boring stuff, I'm not gonna lie, but it is actually where it all happens.
Yeah.
Usually that's true, right?
Yeah. So we're going to switch gears just a little bit here to talk about the federal public health emergency coming to an end.
Yes.
Which we think will happen in 2023 as a condition of accepting the federal coronavirus relief funds in 2020. The state has suspended renewals of Medicaid, all Medicaid renewals during the federal public health emergency. But that's going to change when the public health emergency ends, and states will need to resume renewals.
Which means, just to be clear, has stopped cutting people off of Medicaid.
Yes, thank you, Kate.
If you're not already in that. So the state hasn't been cutting people off of Medicaid during the public health emergency associated with coronavirus.
Yes,
Yeah.
thank you.
So just, I mean, historically, everybody knows that renewal is just a point of coverage loss. It's just, it always is the case that when you send someone a renewal form and you have to send it back, you are very likely going to lose them because they're not going to send it. I just got my second parking ticket thing that was like, you got to respond to this. And so I know that people don't respond to things that are extremely important. And so I get that, like, mail comes, you put it in the front, you say you're going to get to it, the 30 days passes, you don't send it, and then therefore you lose coverage. And oftentimes people don't know they've lost coverage until they go to see their doctor, and then their doctor, you're not allowed in. So what happened is this federal continuous coverage requirement said no renewals. So everybody has stayed in. If they came in, if they were in already in March of 2020, they've been stayed enrolled now for 2+ years. If they came in a year ago, they did not have a renewal period. They just stayed enrolled, and everything has been going great. And there has just been like wonderful stories, although not enough research, although we're really trying to see some good research on continuity of coverage. I mean, we definitely know that people have stayed enrolled, coverage has increased, and people have had continuity of coverage. What we haven't seen is people have increased access to care, and that feels like a good thing to study. But what's happening is that when the public health emergency ends, everybody has to be redetermined. Everybody who's been enrolled since March of 2020. So this is a point of major panic across the country. It's one of the federal government's highest priorities. It's state Medicaid agencies' highest priorities. It's New York State's among their highest coverage priorities. And what the sort of the moment in time that we have is how is New York going to roll out what we're calling the unwinding, the redetermining of all the people who have been enrolled. So usually it's sort of this month-to-month cadence of redeterminations. And now we've got this big backlog that New York's going to move through. Not to mention that New York also has a workforce issue, just like every single other state and every company. There's some real vacancy percentages here. So states have to still process applications, and they have to go through this big backlog of renewals. So the number one thing that we've been doing at Manatt with states and with the federal government is looking at what is the ex parte rate of a state. And ex parte is when a state's able to renew coverage just looking at available data sources. And if the data sources says the person still looks eligible for Medicaid or CHIP, you're good to go. You don't have to respond to my renewal form. So the goal is the higher the ex parte rate, the higher percentage of people we are moving for another 12 months, the smaller the number, the smaller people that are actually getting the renewal form. What we say is anything that's like 70% and above from an ex parte rate is like a home run. You know, like if you can get 70% of your people moved through just using data, then you're really doing the paper and the chasing with the 30%. And New York is there. I don't know, maybe Lara or Kate, if you have the numbers, but in my travels with the New York State Department of Health, top in terms of the ex parte rate. So, you know, that is cold comfort though for the 30% who are going to get the renewal form. And I fully understand that. But related to other states, really at the top, I mean, we've been working with states that at a 20% ex parte rate, and 80% of the people are getting renewal forms. It's going to be a bloodbath. So in New York, if the public health emergency ends in January, who knows, but let's say it does, then the continuous coverage requirements end at the end of the month of January. And then New York will start moving through its redeterminations starting in February, and they're going to take 12 months, and they're going to move month by month. And hopefully they'll be able to maintain the 70 to 80% ex parte rate. They've taken all these flexibilities, they've increased all their verification processes, they've really turned themselves upside down to figure out how they could increase that number so that the real work will be around the 30%. And what we've seen other states do to manage the 30% is the following. Number one is like a full court press, everybody update your address, right? Like, you know, I don't mean to keep revealing what a mess I am, but like also I moved and also didn't update my address and also kept getting calls from people like, hey, where'd you go? And I was like, oh, I'm sorry. So also, as folks who are talking to people who are on the ground, everybody should be getting the messaging. And I think New York is doing a good job, you can tell me, about messaging. Update your address, so they don't have to deal with returned mail, because if they get returned mail, they won't know how to reach the individual. Number two is helping the boots on the ground, all your facilitator enrollers, all your navigators, all your application assisters, to really be kind of on heightened alert that people are going to be getting renewal forms and helping them fill out the renewal forms and send them back. And then also the role of the managed care plan, our friends, they have a vested interest in keeping people enrolled and having the plans do outreach to make sure that people are staying in coverage. So it's sort of a combination of ex parte rates being high, New York, check. Then how do we mitigate returned mail? Let's do a big full court messaging campaign now, and then when the unwinding starts, around updating your contact information. And then once the renewal forms start going out, getting the please respond to the notice that you're going to get in the mail, because this is really important and your coverage is at stake. So that's sort of like the three top things that we're seeing states do. But then of course there's like a million subset of things. But Lara, what are you seeing is happening in New York, and how are you feeling that New York is positioned related to unwinding?
Well, we have several of us in the advocate community have been meeting with the Department of Health regularly, and we understand that they intend to have a wide meeting across various stakeholders, probably sometime in December, so that they can have a broader way of not just meeting sort of sector by sector. And what you're talking about is really very reflective of what we've heard in most of our meetings. I think the scariest thing for most of us is that smaller number of people, because it's not small, it's smaller than the number of people who will benefit from ex parte renewals. But that's that section of that number of people who will have to go through renewals. And then frankly, I think you may have pointed out a few weeks ago, New York is a leader. Once again, New York is doing what they can to get it right. It's sheer volume that is going to be the biggest challenge. And the volume coupled with workforce, it's just a simple math equation. How are they going to get it all done?
Yeah. And that's, I cannot emphasize enough to you that your leadership could not be more invested in this. Like they don't sleep when it comes to their worries and figuring it out and trying to do everything that they can. But the numbers are big, and everyone's going to be looking at New York. Everyone's going to be looking at California. We're looking at Ohio. These are like big states, and these are huge. Pennsylvania, big numbers where it's like too big to fail. And it's gonna, I think, 30% is a pretty large number in New York based on the volume of people who are enrolled. So at the very least, it's just, we'll have to, now I might be upsetting my friends in the state, but I'm gonna just say it. Transparency is gonna have to be really important, right? So there's a couple of reports that have to be submitted, that have to be developed by the state. They have to come up with a unwinding operational plan. They don't have to, CMS can ask for it, but it's not required to get approval. You should get your eyes on it. I don't know if they've made it public. There's a renewal distribution report that states have to submit 45 days before the end of the public health emergency. You should get your eyes on that. How many people are they talking about? What are they thinking about? How are they going to distribute it? And then there's monthly data. It's going to be baseline of how many people we have that we've got to redetermine. And then on a monthly basis, on the 8th of every month, the state's going to report to the federal government how many people were renewed, how many people were terminated, and were they terminated because they were ineligible or they were procedurally terminated. And the procedural termination are people who did not respond. And that's the number you're going to want to look at, because that's the number of people that didn't get the renewal form or got it but didn't respond in time. And that data does not have to be posted publicly, but you should be asking for it, because transparency is the name of the game. And how else can we help figure out what's happening on the ground and mitigate without knowing what's really going on?
Yeah,
and
absolutely.
Laura, if they've agreed to make all that public or not.
I believe that it is anticipated when we have a better sense of the timeline.
Oh, good. That's a good answer. Good for them.
Yes, and I will say, to their credit, as you said, they are losing sleep. They literally, I mean, we believe them when we enter a meeting and they say we're losing sleep over
They
this,
are
we
losing
believe
sleep.
it. And to their credit, they have continued to meet with us. They have continued to fill us in on what the details will look like. And it'll be, we will need to do the job of holding them to the transparency when the time comes, when the timeline is more clear.
Yeah, this is the inside outside part, right?
Yeah, exactly.
Picking up on that, on the transparency and a little bit around accountability, and also kind of going back to the question about sort of contracts and measuring, how good a job the plans are doing, and how, ultimately the states on, health equity for kids. What what data about kids are meaningful in plan oversight? And are there any states that are doing this well, and where they're putting that information out there where it's transparent to folks?
Yeah, I saw. Hi, Denise. So nice to see you. Founding member of Medicaid Matters. I don't have a good state. I think they get asked this all the time, and the measures for kids are not terrific. The HEDIS measures, like, they're sort of like immunizations and well-child, and there's various different states, but I have different practices, and if we get hired by a state that wants us to do it, we'll like pull a million different contracts and see what's out there and pull in our favorites based on the state's goals. But I don't have a state that I can say to you like, oh, they're nailing it when it comes to their Medicaid managed care contract equity measurements. Like, I just don't, but that doesn't mean that New York can't be the leader on this, right?
Right, absolutely.
Yep.
So transitioning to the topic of continuous coverage for young children.
Yeah.
And this is something we had planned to ask, and thank you for the question. Somebody else had asked us about that. So several other states have recently applied to the federal government, or they've approved internally, and they're in a process to try and get multi-year continuous coverage for young children. So, and several of these are large states: Oregon, California. They're all in different places, Washington, I think. So continuous coverage, for example, from birth to age 5 or birth to age 6 for children. Can you kind of, can you talk about what that can look like, and what do you think? I'll say that there are several of us advocates, outside advocates, who've been advocating for this, and having internal conversations, as well as getting some positive signals from the inside, that it sounds like a good idea. But any thoughts you have on sort of how it's worked, how the process has worked in other states, because I know it hasn't really fully been implemented.
Yeah.
And thoughts about New York too.
Yeah. So first, tell me, and I should have asked this before, does New York have 12-month continuous for Medicaid and CHIP now?
Mm-hmm.
Yes. Good. Okay. So here's the fun thing about being a former child advocate. You can go to Washington and Oregon and California and have them do the continuous coverage. So our firm, and I want to say, like, helped get the continuous enrollment for kids in those states. Well, in Oregon and Washington, and not yet California. So that's like the fun thing of like, thank you everyone, because you taught us well. And then we went in and are doing this in those states. So Oregon got approval of a waiver, and the waiver is to let kids age 0 to 6 to be continuously enrolled in coverage from birth until 6. So let's say you don't enroll at birth. Let's say you come in at 3 years old and you're enrolled in coverage. You, little Johnny Smith, can be enrolled from age 3 up until your 6th birthday continuously. There's no renewal. You're good to go. You have to be disenrolled if you move out of state, or if for fraudulent reasons, or all the other, like, there's a couple of other reasons that are consistent with the 12-month continuous enrollment. Also in Oregon, if you are 7 years old or you hit that 6th birthday, you can stay 2 years continuously enrolled. And then you have to have a redetermination. So we're cutting out that natural coverage loss at renewal that we've just been talking about related to churn. That Washington had the first waiver for the record, but then Oregon got in first and they got the approval. And let me tell you something, states are super competitive about this stuff. And so I just want to say that happened. And then now Washington is about to negotiate the 0 to 6, but they don't have the above 6. And then California just got state legislation. Their child advocates got that. And we helped consult with them on what to get. And then now that's going to happen in about 2 or 3 years. So here's the story. This can be something absolutely you should do in New York. There's no reason not to. It will be, first of all, administratively helpful for the state to not have to do redeterminations every year for these kids. These kids largely stay enrolled. They largely don't experience major gaps in changes in their income. We know that to be true in terms of continuity. And when you remove renewal processes and gaps in coverage, then you're going to have better access to continuity of services, which is going to allow the state to measure equity in a way that's much more meaningful, because they're going to have these continuous enrollment spells as opposed to being on and off and on and off. So it feels like this is the moment to strike, because we've had 2 years of continuous enrollment during the public health emergency. And the argument is like, let's build on the successes here. It's been administratively better for the state. It's been better for the families. People have been able to see the doctors get the treatment that they want. And it's a win-win. In terms of like how it's being operationalized, it's a little soon to tell. I think the preliminary conversations we have is that the state will avail itself of like just sort of general data checks that happen, like when Paris, I don't know if you know, Paris is a data check that lets states know if someone's moved out of the state. So if Paris pings that says, oh, someone's got TANF or SNAP in another state, that will be an alert that that family's moved. And then the state won't terminate based on the Paris, that have to then do outreach to the individual and say, hey, are you still in our state? And if you are, let us know. And if you're not, we might have to terminate. But that's really, I think, the only thing that's going to happen. It's going to be on the back end, but it won't be on the family's responsibility to keep things going.
Great. We're excited about that.
Yeah.
Now, I know we're coming close to the end, but I can't not ask you this about mental health, because you can't open a newspaper or turn on television without recognizing that there is a massive crisis going on with regard to child and youth mental health.
I know.
And it's not specific to Medicaid. I mean, it's a crisis among children and youth. And we know that having coverage is important, but it doesn't mean that you're going to get what you need. So can you talk about strategies that other states have used to try to ensure that children, especially those covered by Medicaid, but really, that the system works, the mental health system works on getting kids the care that they need?
Yeah, I would give my left arm to find a state or a series of strategies that together have put it to address this crisis that we're in. I will say it is really where delivery system efforts are being put is how do we solve the behavioral health crisis for our adolescents and for our adults. So a recent report our team put together, I actually pulled it before, just sort of tell you the roadmap that they put together for Massachusetts, which I think could be highly applicable in New York. Is sort of one is, have you all done a workforce needs assessment in New York? I mean, do we really know the story that's happening? Where are there, what type of behavioral health providers do we feel like we're flush? Where do we feel like we have gaps? And, and sort of really understanding what our current state is in New York related to behavioral health and related to adolescents. So it's sort of the number one on the roadmap. The number two is the payments. And where are we in our Medicaid payments for behavioral health providers and the whole universe of providers, not just, your psychiatrists, but your therapists and your social workers and your peers and your community health workers, which I don't think you have yet, but you could. And where are you in relation to other services happening and being in the state, and where, and even though it's hard for adolescents, if you just look at adults, where are our behavioral health reimbursement rates compared to Medicare? And are we at 80% of the Medicare rates? I think that's something we're going to see in 2023. CMS is going to be asking states to sort out. So it's sort of, how are we on the reimbursement rates to make it so that we've got a better provider workforce? And then thinking about, and this, again, all the things, right? There's no one silver bullet, but what's the telehealth success story that we've seen over the last 2 years? I think anecdotally, we love to say that teenagers like using videos and telephone, and states have made a lot of one state Medicaid agency said it so gorgeously. He said we were able to turn our telehealth policy, a 10-year telehealth policy, change it in 10 days when the public health emergency hit. I don't know what happened in New York, but I know in other states they went from pretty crappy to like complete parity on video, almost parity on telephone, very specialized processes for adolescents, understanding that they don't, they might not want video, but they want to be on the phone, thinking about what that is working and how did it increase access, and what do you need to be doubling down on long term for thinking through improving access to and dealing with the behavioral health workforce shortages. Again, Kate, I wish I had all the answers on that one, but these are just like a couple that I think are helpful that I know other states are focusing on.
Well, I'll note, because I think on the issue of workforce is so important, and we really supported a law that just got passed that New York is now going to be collecting better data on the health workforce. So there's a whole array of professions in the health workforce, and we really have pretty much zero information on who's doing what and where, and are they thinking of retiring next year? Where are they in their careers? Are they even working in their field? And so the health workforce data bill, which the state has yet to put any money behind. So those of you who are here and really think that we should actually have a little bit of information about the health workforce, can urge the state to put some money into actually doing the data collection. Because it's not going to happen without the workforce, and we need to know where they are in order to be able to do that.
Yeah, and workforce challenges with nurses in hospitals is different than workforce challenges with home and community-based service workers.
Sure.
It's different from behavioral health providers for adults and MAT, and different than, right? And
entirely, so well, you think of early intervention for, people who are different, are different kind of occupational therapists, speech therapists. They're all considered the health workforce. Absolutely. It's different than,
and your solutions are different. So
absolutely.
that's the challenge. I mean, I've been in this world for 20 years now, and this is where I want to spend time. Like, if you tell me, like, where do I want to learn more, I want to help really think about the workforce, because it's focused on coverage and delivery system, and I really do believe that's sort of, where I think I could have a really big impact is if I really started to understand it in a way that was effective. What are the real solutions there?
I'm with you.
Yeah. Let's do it together.
Okay. Well, I think we promised our group that we'd be finished by now.
Okay.
And we're so appreciative of having you here. If you have any sort of parting thoughts for us, please share them. And before you do, I'll mention that Schuyler Center is co-hosting an early childhood oral health summit. It's next week on November 14th, and oral disease is the most common chronic condition among children. It's preventable, and it's a condition of poverty. And so Schuyler Center's upcoming New York State Early Childhood Oral Health Summit is on the 14th if you go to our website and go to events, you can register for it, and it's being co-sponsored by a fantastic group, the Early Childhood Advisory Council, the New York State Dental Foundation, the Head Start Collaboration Office, the Department of Health, and the Council on Children and Families. So I'm sorry we didn't talk more about oral health today, but those of you who are interested in oral health, please, join us for that. And
It's amazing. It's
yeah.
amazing that you're doing that. Everyone should do that. Go to that. I just had one small point, and then because I don't want to keep everyone, but just to say, like, elections tomorrow, everyone's going to vote. We know that, and then things are going to get crazy, and it's going to get crazy on two fronts. One is the Biden-Harris administration is going to be going full-throated regulatory release because they have 2 years, they think, before things might really change for them. So your state is going to be doing public health emergency unwinding while also having to manage a set of regulations that are coming out on eligibility enrollment and managed care. So give them grace and be supportive to them, because it's going to be the same 5 people that are doing everything, and it's a lot. And then number 2 is there's also going to be a lot of stuff that's going to be happening from the congressional perspective on the federal side that's going to require some real advocacy work to figure out how to stem that in any way that needs to happen. So thank you for all that you do, because there's going to be so much work ahead. No question. But thank you. Such a pleasure.
Thank you, Kinda.
Thank you all for joining us.